The BC COVID-19 Modelling Group has been meeting twice a week since March 2020. We are an independent, interdisciplinary study group of scientists mostly located in BC and including scientists from UBC, Simon Fraser, the University of Victoria, other places, and in industry. We use mathematics to understand the course of the pandemic and the effectiveness of various interventions that have been applied to mitigate its severity. We are particularly interested in the situation here in BC, but we seek to use information from around the world in building models and making predictions. I would like to gratefully acknowledge support for our group from the Pacific Institute for Mathematical Sciences. This modelling report features modelling developed by multiple group members to describe the current situation in BC and make projections that include the effects of variants of concern, the BC vaccination program, and our society's efforts around social and physical distancing. These models show a great deal of consensus, and in fact, this report represents the consensus view of our group. This video is an extract from a recent Zoom call hosted by Rob James and featuring Sally Otto and Colijn, both of whom have contributed substantially to the work being presented. Sally is a Canada Research Chair in the Department of Zoology at the University of British Columbia, and Colijn is a Canada 150 Research Chair in the Department of Mathematics and Statistics at Simon Fraser University.
Our goal is obviously to work together to improve public health response and public responses to this pandemic. And many journalists have asked several of us, Colijn and I, for our modeling results. And we decided as a group that it would be good to make public what we are learning and what we are exploring in these models as we go. So that's the intent. And I really have been very impressed with the Ontario Science Table and their regular reports. And I think that that independent voice of what we are learning about this pandemic can be helpful. So that's in that context that we present this to you.
At the start of the pandemic, I and Dan Coombs from UBC joined forces with the BC CDC modeling teams, and they didn't have a large modeling capacity. They seconded a couple of people from Dan's group, and we've been meeting weekly and collaborating on modeling since the start of the pandemic. The modeling needs just go beyond what one or two staff members within BC CDC can really do, because they also do their regular reporting and data analysis. So we've been supporting that team heavily at first, and then they've built their capacity out a little bit more since then. And we've also been working with this independent group that Sally is sort of co-leading, that Dan and I started early on in the pandemic, must have been a year ago, maybe last April or even March. So these kind of have been going in parallel, and that's allowed Dan Coombs and I and Mike Irvine and a few others to really be a strong bridge between this group and BC CDC. So it's an independent group, but it has kind of strong links and weekly interactions with BC CDC and with their modeling work that they do internally, some of which we support, and then some of the work that they do internally comes out in the public via papers and things. And so it's integrated, but this is independent modeling.
Thank you for that. And so this particular report has slides contributed by a subset of us. And so I will tell you what our models are saying. And I should add that I think one of the strengths of the team has been that we have different scholarly experiences and perspectives, and we approach modeling in different ways. And so sometimes I'm going to show contributed by different teammates, but I think what that does is it helps us get a sense of how robust our inferences are. So the key messages from this modeling report is that the growth of variants of concern, B117 and P1, has driven the recent rise in cases in British Columbia. That transmission rates, and that's reflected in activity levels and contact rates and chance of passing on the disease, must be reduced by about 40% to control case growth. And that's 40% reduction relative to February, March levels of contact rates. which were already, of course, much reduced relative to before the pandemic. Hospitalization numbers and ICU numbers are projected to rise above capacity in May unless virus transmission is brought under control. And the vaccination program needs to swiftly target those with the most contacts so that infection and hospitalization rates can also be reduced over the next 2 to 3 months. So those are the key messages. What are the kind of model results? So this first picture is from Jens van Bergman, and this is mainly just trying to say, where are we in BC following a year of COVID cases, the daily number of cases in gray dots, and a fit to those curves. Major shifts in, of course, the disease is not just about a virus spreading. It's about our human reaction, our social reaction to this virus. And so also shown here are the major public restrictions and openings that have happened over the past year to control the virus. And those have had major impacts on the slope, on the rate of decrease or increase of the virus. So public health measures have been really critically important in kind of keeping the numbers under control. The recent surge in cases, so this is the April, end of March, early April, surge in cases is driven primarily by the rise in B117 and P1, and I'm going to call those the variants of concern, VOC for short. So this is from the PCR assays conducted by the BC CDC to detect the variants. They all share a change in the spike gene called N501Y. So that's what these PCR tests are screening, and they're screening a very large proportion of cases from February onwards. So these data points are the rise in total case numbers based on those percentages from large surveys from PCR. So thousands and thousands of cases have been surveyed. The variants have grown exponentially, doubling every 8.6 days, 8 to 9 days over this February-March time period. And just to guide you, the exponential growth, I just pivoted that slope downward by saying what would happen if we reduced transmission rates, contact and activity rates by 20% or 30% or 40%. And even in this very simple illustration, you can see already that to counter that spike in cases, we would need to bring down transmission by 40%, a number which we'll come back and see again later in more sophisticated models. So far these graphs are on total daily cases. I just also wanted to show you the active cases. This is reported in the joint statements that are released from the province. This is the in gray are the total active cases, and in pink are the projected active cases based on this growth in the proportion of cases that are due to variants of concern. And so active cases are making up, our VOC is making up a large proportion of the active cases now in British Columbia. And that's hard to tell from the joint statements because the joint statements only report confirmed cases. Well, what are those confirmed cases? Those are the ones that have been sent to whole genome sequencing and that have been confirmed. And then those cases have to still remain active. And so you can see here that that's really a small proportion of the projected active number of variants of concern. This is the same data, but a smooth fit to guide the eye and really help us see just how much the variants of concern have risen in British Columbia and are now the dominant virus circulating. This is a different model fit to data. It's from Dean Carlin from the University of Victoria. And his model uses a kind of underlying disease dynamic model of infections and takes into account how long individuals are pre-symptomatic, how long they're infectious, and the chance that they then get hospitalized. And the key part to his model is that he fits breakpoints, that these are these dashed lines, for when there appears to be a shift in transmission rates of the virus. And so a lot of times, so those are basically inferred breakpoints. And between those times, he sees fairly regular patterns. And so the model fit in solid is one of the, in solid green here, to the dotted lines, which are daily averages, and the bigger dots are weekly averages. And as you can see, the data fits very well. And this is one of the better predicting models in the United States. It's used there in competition with several other models and performs very well. So here we have the total cases and the rise in the variant cases based again on the data provided by earlier, based on PCR. And this is the data that's fit. And it also does a reasonably good job of predicting both hospitalization numbers and ICU capacity as well. So these are not fit to the data. They are projections about what will happen to the data. And here too, on the right, we have potential outcomes if starting in end of March, beginning of April, there's a shift in transmission rates. This is a different picture of the same rise in cases. This comes from Colijn and her group, and is one of the most commonly applied models across Canada to project case counts, including here in British Columbia. And this accounts for the rise in the variants of concern to give an overall projection for what will happen to case counts as they're projected over the next month. I should say that this projection does not yet account for changes that may or may not have happened on March 30th. Just because we don't yet have enough data to know whether or not the new restrictions, which closed restaurants and had a few other changes, whether or not they're bending this curve down yet. This curve, this slide, it tries to explore where might we be following March 30th. And as I mentioned, it's too early for a robust statistical measure of whether we've bent down the curve. But this is just to guide our eyes. This is a trajectory expected from February and March transmission rates. And these are these lower transmission rates if we have indeed reduced our contact levels. The red shaded region based on the variants of concern and the total case numbers. And this helps you see that there seems to be a recent dip below what we might have otherwise expected, perhaps suggesting somewhere on the order be a 20% chance, a 20% reduction in transmission rates already, given the end of March restriction measures. So what will that, how will that play out if we've reduced the spread of variants of concern? And of course, we're ramping up our vaccine. The million-dollar question is what's going to happen over the next couple of months? And so that's where models can help guide us and guide our policies. So the model I'm going to show you is one that I developed. It's based on a compartment model of like an SIR model, but with more compartments: susceptible, exposed but not infected, pre-symptomatic, infectious, symptomatic, and then recover. But this model allows for different age classes because hospitalization rates and the chance of death, and also the vaccination plan depends on age classes. So it's broken down by age classes, and also allows for the possibility that many of us can work at home and be very socially distant, but there are a lot of essential workers and others that must remain active and are otherwise remaining active. So it has two distancing classes, one that are able to distance and one that continue to work. So any projections at this time are challenging because of the rollout of the vaccination plan. And so this slide just illustrates what the model assumed about the vaccine rollout schedule. These colored graphs are based on the calendar of when it was said that each age group would be vaccinated based on the different age groups. This bulk curve is the total was matched to these projections, but this is what is used in the model to come. So a couple of comments about assumptions. This is the BC population size. This age-based rollout plan assumes 85% vaccine uptake rate. That's based on the reported number from the Public Health Agency of Canada. And that's actually on the upper limit. That's about the vaccine uptake rate that we see amongst the more senior members of our population. Younger individuals have a lower rate of vaccine uptake, something closer to 70 or 72%. And in the slides that I'm showing next, we're making the kind of optimistic assumption that we can beef up vaccine uptakes among everybody so that it's assumes an 85% uptake rate for everybody. I also added in, it doesn't make much of a difference to the projection, but I added in youth vaccination in June or July, assuming that vaccines are approved at younger ages soon. So besides depending on the vaccination rate, the other really critical determinant of the model projections is the rate of what we do and how our measures, our mitigation measures, slow down the spread of the variant. So in everything I'm going to project, I'm going to have 4 different columns for if we didn't bend down this curve and we have the same sort of transmission seen in February and March, or if we were to have bent it down by 20, 30, or 40%. As I mentioned earlier, it's too early to tell, but suggestive evidence that maybe we have reduced it by 20%. All right, so here are that model is projected forward to, it uses March 30th and the growth rate of the disease on March 30th and the case numbers on March 30 to anchor the projections, and then otherwise just runs forward in time. And as you can see, we expect if we continue to be as active as we were in February, March, because this variant of concern just has a much faster upward curve, it takes more to bend it down. And if we continue to move about as we did in March and February, then the case numbers, this is the number of variant cases only per day, are just going to continue to surge out of control. Here is the projection where we shifted down our transmission rates by 20% on March 30th, 30%, and 40%. And the key take-home message is that 20% is going to help a lot, but it's not enough to prevent the surge in case numbers. That really we need to see 30 and ideally a 40% reduction in transmission rates relative to February and March in order to stop the rise in cases. And just to emphasize, this includes the rollout plan for vaccines. This was for number of cases, and here we see the same sort of the spike leading to a rise in demand on hospital beds. Sorry, everybody. These shown relative to the maximum available hospital beds according to Minister Dix in his public statement yesterday. So that's open beds plus all of the surge beds that they've made available for COVID. So this is the capacity in our hospitals. And rates, we're going to soon overrun capacity. And even if we have reduced transmission by 20%, we're going to exceed capacity. So a greater decline than that is going to be needed, and certainly continuing on in our restrictions is going to be needed in order to see these types of reductions in transmission that will keep the hospitals from overflowing. And I should just also say that this dashed line is the previous maximum number in hospital from the non-variant over the course of the pandemic prior to the appearance of the variants.
So you're really looking at a fold difference between the maximum previous hospital occupancy and this putative hospital capacity number, which is about 3,200. That's a six-fold difference. I just want to underscore that.
Yes, that's right. And this isn't the total number of hospital beds, which is closer to 11,000. But of course, those hospital beds are mainly full with people that really need to be in the hospital. So this is just what is our capacity without kicking people out of the hospital. This is a different metric here. This is the number of ICU critical care beds, the total number, whether or not it's base beds or surge beds, whether they're occupied or not occupied. That's what these thick upper lines represent. And again, the dashed line is the previous maximum. And the story is very similar. We need to reduce our transmission rates relative to February, March, in order to keep the ICU numbers from growing out of control. And we started exploring these models back a couple of weeks ago, and indeed are now seeing ICU numbers having reached higher than they ever were before in the pandemic, as you may know. Oh, I should also say in these projections, I did assume that the variants of concern were more severe and more likely to cause individuals to need to be hospitalized or to go to ICU. And I used a number from a study from Britain of a 64% higher severity of these VOC, but that's really similar to what they're seeing in Ontario and elsewhere. And the death rates, so this story is somewhat different. The death rates relative to the previous maximum, we may not see major rises in the death rates relative to that previous maximum, maybe slight ones above, but because our vaccine is working to bend down and limit the impacts on death rates of our most elderly population. So key messages, we have to bend down the reduced transmission levels. And if we have already succeeded perhaps to bend it down by 20%, that's not enough to avoid overwhelming hospital capacity. We need to aim for reducing transmission by 40% relative to February and March in order to avoid further increases in hospitalization, ICU, and death rates. And of course, delaying those actions will cause a rise in cases that will then lead to higher impacts for longer. So the earlier we act, the faster we can bend down this curve. I should also say that so far, everything that I've presented has not teased apart P1 and B117, even though both are very common in British Columbia, simply because the data is not made available that in a way that distinguishes between the two. So everything is lump them both together and assume that they have similar properties. The projections may be somewhat optimistic if if vaccine uptake is less than 85%. Oh, and I should add that I've assumed in these projections that the vaccine is after 2 weeks, there's a 2-week interval when it has no effect, and then after that it's 90% effective at reducing infectiousness and severe outcomes. It might not prevent infection But if you are infected, the viral dose is low enough that it prevents infectiousness as well, at a rate of 90%. And so this is probably on a somewhat optimistic. And by targeting vaccines at transmission hotspots and really reducing case numbers throughout the province, that will buy us time for rolling out the vaccines. So what can we do? It's one thing to say we need to reduce VOC transmission. These are very much in line with the public health messaging that has come out globally and in BC. Certainly, we're starting to see BC shift towards more rapid testing, and I think that can help. And we really should be throwing everything at the variants to help bring the case numbers down. And that includes using rapid testing to detect and isolate individuals who don't necessarily yet have symptoms, asymptomatic cases, and those pre-symptomatic cases. Targeting vaccinations to locations and sectors of the population most at risk, the ones that are have the most contacts or are the most vulnerable, as that will reduce transmission rates as well as reduce hospitalization demands. We all should reduce indoor exposure, increase ventilation when indoors, and that can help offset the potentially higher risk of droplet and aerosol-based transmission that we think is happening with the variants of concern. And another aspect that can work if we, as long as we keep the case numbers down, is that our contact tracing can be expanded to include not just the contacts of primary cases, but the context of those contacts. And that's possible, especially if we couple contact tracing with rapid testing of asymptomatic cases, to be able to identify those contacts that are infected but don't yet know it, have no symptoms, and get them isolated first, and in turn catch their contacts. So that kind of can wind in all of those potential lines of transmission and prevent them from spreading further. Of course, they say garbage in, garbage out with models, and these models are models of SARS-CoV-2 throughout the pandemic have been limited because we know so little about this virus, and the models have had to adjust and accommodate uncertainty in all of the parameters and changing knowledge. But here in British Columbia, this access to data has been particularly challenging. And so we make some suggestions for ways that can be improved. The PCR assay for variants of concern is excellent. We really applaud the province for typing so many cases so quickly. It's within 24 hours of the case test being positive. And so we expanding that use to not just say whether it's a variant or not, but to distinguish the P1 from B117 and other variants would be highly recommended. Reporting, most of the data in this report really relied on those PCR assays, the ones that type the variants of concern. And this is what would be great to have reported daily. The whole genome sequencing results that can be reported at a slower interval. Those, of course, are very important for finding new variants. And so those whole genome sequencing reports should continue to come, and they can contribute to global surveillance for new variants. That's especially useful if it's coupled with the kind of information that all the genomes should be should have when they're contributed to GISAID, and that in particular includes sample date. So in Canada, many of our whole genome sequences are submitted without the sample date. So that's another thing we need to improve. And other data, and this is a bit more technical, I can skip it for now, but there's other recommendations for essential data needed to report, in particular sample sizes, so that we know of when we get this many PCR reactions are positive, well, how many were tested? And for vaccinations, the models on the projected race between the variants of concern and our vaccination rollout plan depend on assumptions about how the vaccinations are rolling out by age and by location. And so having more data about where exactly our vaccines are going can allow us to update these projections. So just to conclude, our models give good predictions for the short term. They've been validated, and Carolyn's models have been validated over the course of the year, again and again, with respect to COVID projections. And we've seen the predictions about ICU numbers matching the predictions. But of course, more accurate models are possible with greater and more timely access to data. And with that, I think I will end there. There's a few additional information slides. This one shows the rise in the variant divided by the non-variant. This allows us to measure the selection coefficient favoring the variants of concern. And this is more information about that estimation procedure, but I'll stop there and answer any questions. Maybe to start, Carolyn, any thoughts that you'd like to add?
Yeah, I think one of the things that we keep getting asked is, are we winning this race with vaccination? And right now, I think that the punchline here is maybe we will eventually, but we're not right now. In the next 3 to 6 weeks, we're not likely to kind of deploy enough vaccines to get out ahead of transmission chains. And so I think that's one thing that hopefully is relevant to you, because we won't be able to stop transmission fast enough with vaccination. And the other, I guess, is that, this idea of kind of, we were doing okay, like really the driving force here is that increased transmissibility in the variants. So it's not that kind of different measures are needed. It hasn't suddenly become a virus that jumps from car to car instead of person to person. It's still a respiratory virus. But it could be that it needs a smaller viral dose to get into the body, that it attaches more easily to the cells, that it invades the cells or replicates more easily or at a higher viral load. We don't really know those mechanisms, but they could mean that smaller droplets or aerosols are more relevant. So I think there are some public health implications here that we don't really know, but maybe we could be using a precautionary principle to thinking about, what if it is really small droplets? What are we going to do? How are we going to get in front of that transmission? Because we're kind of putting all our eggs in the vaccination basket in a way. And in the short term, I think that's we're still facing a challenge. In the longer term, if efficacy is undermined by escaped variants, we're going to need to be thinking about that too. But we focused here on the kind of shorter term.